Hello, everyone, and welcome to today's webinar. I'm Rhonda Ann Gerst, the Rural Health Clinic Program Manager here at the Oregon Office of Rural Health. Kate Hill from the compliance team is with us today to present RHC, What Now After COVID. Kate Hill, RN, is a graduate of Einstein Medical Center School of Nursing. As an RN nurse, Kate served in Viet Nam, where she was awarded the Bronze Star. Kate has worked with orthopedic patients in several capacities, including nearly 3 decades with Biomet. Kate joined the compliance team in early 2012 to direct the compliance team's Rural Health Clinic Accreditation program and has fallen in love with rural. As the VP of Clinical Services, she has spearheaded the compliance team's Rural Health Clinic Accreditation program, combining her clinical expertise, business acumen, and passion for delivery of the best care possible to every patient. She presently serves on the board of the National Association of Rural Health Clinics and on the Congress at NRHA. She feels fortunate to speak at numerous state and national meetings about RHC compliance countrywide, which gives her the opportunity to learn firsthand the diverse issues clinics are facing. Kate lives in suburban Philadelphia with her husband and near her 3 granddaughters. Before we begin, I have a few housekeeping details. This webinar will be recorded and the recording and slides will be posted on the Office of Rural Health website within the next few days. A big thank you to Eric Jordan, who is our tech support during the webinar. If you have any technology problems, please enter questions into the chat box and he will address those. You are all currently muted and your video is off. If you have questions during the webinar, Kate will answer your questions. Enter your questions in the chat box and I will be happy to read the questions for Kate. Without further ado, Kate, the floor is yours.
Well, hello, and thank you so much, Rhonda Ann, for that wonderful introduction. I have a little piece of news as of January 1st. I am now on the board of NRHA, and I am so honored about that. That is just an amazing thing to me. Little kid from Calmer, PA, you know, kind of wonderful thing, because I love rural. I want to do everything I can for clinics. So when Rhonda Ann asked me to talk, it was a bit ago, and what now after COVID? And I'm like, but yesterday I'm thinking about this and it was a little late. I should have thought about it sooner. And I'm like, after COVID, we're not even there yet. So it's kind of like I don't know what to talk about kind of thing. So we'll see how we go here. First, I want to thank you all because what you do out there every day is so critically important. And we really thank you for what you've been doing for 11 months now. It's just an amazing thing. What a time. I'm no youngster and I've never seen anything like this my whole life. So here we go. So I found this. Yes, I love this. I will wear my mask here or there. I will social distance anywhere, everywhere. So I thought that was kind of cute. We could kind of make that our mantra. I read those books to my grandkids. So we kind of know those doctors, Dr. Seuss books. And so I will wear my mask here or there. I will social distance everywhere. That's a good one that we should, and we need to do that, of course. And we need to wash our hands. Now, because I have a kind of a mixed message here on what I'm going to talk about, there's a lot of different things in this slide presentation. So we'll go with what we've got. If you have questions, ask away. Some of this is obviously going to be review. I thought this was fascinating. I spoke to your group in May when you had 29 deaths in Oregon, and you are now, as of yesterday, at 1808 in that time period. That's just amazing. It is lower than some states, but it's still awful. It's 1,800 precious lives lost. And so really just what an event. I just can't even believe this is happening. And those numbers I took right off your state Oregon Office of Emergency Management. So a little review: if you feel sick, stay home. If your children are sick, keep them home. If someone in your household is tested positive, keep the entire household at home. If you're an older person, stay home and away from other people. If you're a person with serious underlying health conditions that put you at increased risk, stay home and away from other people. Again, there's a fair amount of review. Now, for the foreseeable future, and again, we don't know the end here. Nobody knows the end date as we hit the vaccine now. Continue to monitor your staffing levels necessary to operate and who has higher levels of risk. Any non-essential employees should continue to work from home when possible. We're still at home. I'm sitting in my home. I travel a lot, or in 2018, I traveled a lot. I haven't been anywhere since February of 2020. Continue to ask patients and clients if they're symptomatic. Continue social distancing, of course. What is working and what is not? Let's keep looking at this so we can know how to move forward, what hasn't worked, what has worked. Update and review infection control prevention policies constantly. I mean, we're looking to keep it as low as we can, where we can. Update and review emergency preparedness policies, and be prepared for what I don't know. For enough vaccine, for an onslaught of vaccine that comes to your clinic. We've had it yesterday. We had to cancel a survey because they got a load of vaccine and didn't have patients lined up. They did not expect that shipment. It was like 150 doses. Well, my goodness, grateful that got them. We're not going to be doing survey for sure. So be prepared for the unforeseeable, I guess is the only way to put that one. So your Office of Emergency Management, a wonderful little group of things here to do your part: social distancing, good hygiene, responsible shopping, preparing your home, protecting your mental health, coping with stress and crisis lines, big problem today, and be 2 weeks ready in your home should something else happen, which I would believe at this point. You still should have your clinic door sign. So if someone's experiencing these symptoms, that red sign should be on your front door. They should go back to their car and call you. Put your clinic phone number over, make a sign, and you will go outside to them still after all these months, because we don't need that person coming into the clinic potentially contaminating a lot of people. And then you make the decision where you're going to dispense that patient to. In the cleanliness of the place, we recommend use of EPA registered household disinfectant, that website, sorry about that, because we're finding clinics using disinfectants that don't kill even HIV and Hep B, let alone COVID. We had one a couple weeks. COVID-19 would kill that. It was a 12, 14-minute wet time. Well, they didn't read the label. And so they were just wiping down, putting the paper on. That's not going to kill anything. All you've done is sucked it up in the paper. So read those labels. If you're finding a new disinfectant and some things are changing where we can't get what we used to get, we got to get a new one. Make sure you know what's on that label to ensure safe and effective use of the product. And many products recommend precautions such as wearing gloves or making sure you have good ventilation. Read those labels. And of course, you should always know the wet time for your disinfectant that you're wiping down those surfaces. Ensure your staff is trained on the hazards of cleaning chemicals in the workplace in accordance with OSHA's hazard communication standard, and that is a link to that. Comply with OSHA standards on bloodborne pathogens, and that link, and including proper disposal of regulated waste and PPE. All these things are more important than ever as we battle this pandemic. So I really think it's important that we stop and remember about our staff. And those people listening, many of you are probably managers, and you are uniquely positioned to serve as influential role models for compassionate acts and demonstrating care for people's basic needs. Showing interest in your employees' feelings can be key to recovery. They need to recover. You need to recover. And so we need to be tapped into this because it's been a long, hard battle. Checking in on individuals and their families, people that are at home, maybe they're quarantined. Are they okay? Are they getting food? Do they live alone? All those things. And expressing gratitude to our staff with small words, small tokens of appreciation, setting up a clinic thankathon of some sort. Thank your providers, your staff for working so hard throughout this whole thing at great risk to bring this thing home to their families. Leaders should also encourage and raise the profile of compassionate acts on the part of employees to further foster a mutually supportive community. And of course, we need that as a nation badly, but we gotta start somewhere. So let's start in our homes and in our clinics. So I don't know if you realize that safety, honesty, and caring is the motto of the compliance team. Owned and operated by a nurse, and that's why that came about, and that's a good thing. But always consider what matters most to your employees, to your staff, to your community, and I see I put staff twice, I apologize, and to yourself. You need to be caring for yourself. You're no good to anybody if you don't care for yourself. I'm my worst enemy on that one. I'll admit it. My staff tells me that all the time. Go to bed when I'm texting somebody at 10:30 at night. I get it. It's hard to do. We're workers. We just keep rolling. And so we need to remember that we're really important. If you don't know Leanne Thiemann, Theiman, it's Chicken Soup for the Nurse's Soul. Highly recommend her podcasts, her website. She's in Colorado. She's wonderful. And it's soothing stuff. It truly is. And we need that right now. I can't watch the news anymore. So just from one thing to another, it's just brutal. And so it's really not healthy, is it? So we have to care for ourselves. Now, I wanted to remind you, because this came up yesterday, that there are still 32 CMS RHC waivers. There's many, many waivers, but there's only 32 that apply to rural health clinics. I had a call yesterday. Can I give vaccines in my parking lot? Well, yeah. Can I give vaccines down the street to make that a spot? We've got an empty space to just do vaccines. Yes, and bill it out of your rural health clinic. And it's all covered in these waivers. Of course, beneficiary location for telehealth services has been a big one. NARHC is working hard, as well as NRHA, to get that written in the law. We can't put that toothpaste back in that tube once this pandemic ends. We can't just stop doing telehealth. It's not going to work that way, and it shouldn't. It's been a benefit, but you'll decide where and when you want to use it. But we need to get the payment set up and all that. So for telehealth, your providers can be all over the place, basically, providing that telehealth. There are additional telehealth services covered by Medicare. Billing is not my area, so I'll just walk right by most of those. But virtual check-ins, remote evaluations, and e-visits are all permitted on a variety of platforms at this time. Right now, that time is to April 20th, just extended by Secretary Azar. New secretary today, I have to get that name actually, but he did extend it on January 7th. So all these waivers are good until then. Remote patient monitoring, eligible practitioners, people from out of state, as long as there's some real specific guidelines for that. Practitioner locations. CMS is waiving the Medicare requirement that a physician or non-physician practitioner must be licensed in the state in which he is practicing. So you can have somebody, if you're on the border, with another state, as you are, is one side, two sides, three sides. You can have practitioners come across the border to help you from the different states, even if they aren't licensed in, and it's approved right now. Allowing RHCs and FQACs to serve as distance site for telehealth. Of course, I mentioned that. Audio only telehealth for certain services, and that's allowed. Temporary expansion locations, that's the big one that I hear a lot about. So we have clinics that, particularly when they're located provider base pretty near their hospital, they can have a space in the hospital that's for their sick patients, and they keep the clinic just for well patients, so they get people coming out for their checks, their annual wellness visits, their welcome to Medicare visits, all those things. And so that's still all covered until April 20th. So don't miss this opportunity to separate things and keep people, if you have enough staff. And of course, that's the big issue with people dropping like flies, being ill, and pray they get well. But there's many instances of that around the country. Bed count for provider RHCs and RHC payment limit is changed. I didn't write all the words for that. It's a big one. I will show you where all these waivers are. Cost reporting has changed. Stark law waivers have changed, and provider enrollment. Now, if you're going to start a new clinic, the 855 approval process is free. That's a good time to do that if you have the wherewithal to do that right now. Go in Pecos and you can do your 855 for free, and that saves you $600 right off the bat. Advanced beneficiary notice has changes. Medicare physician supervision requirements have changes that can be provided virtually, where before they might have had to be real time, and that's a new thing. Now, we don't see much of that in rural health clinics face-to-face, but still. Practitioner locations, again, that must be a little, oh, I know, this is where the guidelines are. Must be enrolled in the Medicare program in that other state. Must possess a valid license, of course. You want to make sure you have that. And is furnishing services, whether in person or via telehealth, in a state where the emergency is occurring. Now, we have that in 50 states, so there's no issue there. And is not excluded from Medicare. So you might want to run them through the OIG exclusion database before you work with this provider. But that's still a help to you who are so short of providers at this time, both NPs, PAs, and MDs. Her nursing home visits, fewer requirements to get those done right now. Again, all covered. CMS is waiving the requirement that a nurse practitioner, PA, or midwife be available to furnish patient care at least 50% of the time the clinic operates. Note, they were very clear in this. They did not waive that one of the providers needs to be in the building at all times when you're providing care. It's just that if your NP gets pulled to the hospital or is ill, you can fill in with others, with doctors, if you have them, and you don't have to worry about the 50% of the time, as long as there's a public health emergency, all right? CMS is modifying the requirement that physicians provide medical direction for the clinic's or healthcare activities. Now, let me just say right there, because we get a lot of the new clinics coming in and they're having their surveys. None of these waivers apply to initial RHCs coming for surveys until you get your billing number. You're not an RHC yet. And we had to fail a clinic. They let their NP go work somewhere else because the need was greater in another clinic. And we went to survey and they had no NP and they can't pass survey. So for rural health clinic survey for an initial, not renewals, not your reaccreditations, but for initials, you must have that NP there, all right? And none, like I said, none of these waivers apply, all right? Very important. So these are all different ones. Modification of 60-day limit for substitute billing, accelerated advance payments, suspension of Medicare sequestration, COVID-19 diagnostic codes, high production COVID coronavirus lab test, antibody test, COVID-19 FAQs. All these things are in the waivers, and you're going to get them at this website. Now, what the government has done is put 100 and some waivers all in one document in fine fashion. And so you need to go in there and make sure you are searching only for the 32 that apply to rural health clinics. I pulled them out and put them in a document. I will actually send those to Rondianne so you have those for your use, so that you can know what to find there, where to find them. All right. Number 30 is COVID-19 stakeholder engagement calls. I've seen this in Illinois with that region of CMS. I suppose you have them. I've not actually noticed any others. I don't know why I get theirs, but there are stakeholder engagement calls. They're really good to log in and see what you hear, different things. Most of it tends to be billing. Okay. The Office of Minority Health has some waivers, and then interim final rules and waivers. That's a different web page. And you go to CMS Emergency Preparedness Response and all the rest of it to get all of this. It's a well worthwhile journey to look at these 32. And again, I'll send them out to Rondianne. So if you are as you are, I should say, required to do an exercise a year, one an active and the opposite year a tabletop perhaps, you have lived an exercise for going on 11 months now, soon to be 12, soon to be a full year of this. And so if you're not using that as your event for the year, well, I'd be very surprised, but you must write it up. And it's not a problem. We've passed many a clinic writing this up now, even back in the fall when it was only 6 months in, but you're now well even past that. There doesn't have to specifically be an end date. And I should have changed that to 21 because we're still not done. So this is an example of what you can do to pass survey, to write up your COVID-19 after action report based on the event called COVID-19 Outbreak 2020 and maybe -21. Your clinic name, the date the event began for you, the date the clinic ended, and you can use the date that you're writing the report. You could use today if you're writing a report. It does not have to be the end of the event. It certainly isn't. We're sitting at about 10 months now. The purpose of this report is to analyze event results, identify strengths to be maintained and built upon, identify potential areas for further improvement, and support the development of corrective actions that will guide future emergency preparedness initiatives to advance overall emergency preparedness within our clinic. So that's the goal of this little report you're putting together. Certainly copy and paste that. It's not anything that I'm going to be upset about. January 22nd, the CDC confirmed the first COVID case in the United States. January 30th, the World Health Organization declared the outbreak a public health emergency of international concern. January 31st, Secretary Azar declares a public health emergency in the United States. March 8th, Governor Brown, your governor, declared a state of emergency and activated the Emergency Operations Center. March 11th, the COVID-19 outbreak was characterized as a pandemic by the World Health Organization. March 13th, President Trump declares a national emergency concerning the COVID-19 outbreak. And of course, the latest, January 7th, Secretary Azar extends the public health emergency. So every time it's extended, it's another 90 days. There's no way to know what's going to happen around April 20th. What President Biden will do, I have no clue. His new secretary, whose name I shall get before the day ends. And the issue there is it's the waivers. So you're covered on a lot of things as long as those waivers are in effect. And if we're still battling this, I suspect it's going to have a lot to do with vaccine distribution and how quickly we can get this ramped up. So your executive summary, this is all, you're going to type all these slides into your report. This event in the first half of 2020 occurred as a result of coronavirus from Wuhan, China, which resulted in a worldwide pandemic. The event began for your clinic on March whatever. The emergency team was composed of, and that's your team, your leadership team. What were our major strengths? What did we do well? We did staff training on infection prevention. We planned to triage patients who come to the clinic. We put a sign on the door to call from the car if symptomatic. What did we need to improve? We needed to order extra supplies such as masks and hand sanitizer earlier. We still need to order supplies and hand sanitizer now. We need to minimize things in the waiting room to decrease things needing disinfectant. They should be as sterile and as bland as they can be right now. We need more screening of clinic staff, temps in the morning, which should still be going on. And we need more separation of patients. So that's my little list from just what I hear. You've got your own. You know what you did well, maybe what you didn't do well. We didn't get it quick enough. We couldn't get hand sanitizer, all those things that happened last year. So let's celebrate our successes as well in this little report. The staff immediately began calling patients instead of visits to decrease exposure for patients. The staff sent some to the hospital to assist with surges as they came and went. So these are our successes. Our providers maybe worked from home to do telehealth. That's a huge success, and it works particularly well for the older providers who don't want to be exposed, can't take that chance, but they can still talk to patients all day. It's really a very good thing. Put a little chart together. What are the observations was lack of supplies. We need to keep more on hand. We ordered them. We did a plan of correction for that. We started that in June and we got it all squared away by July 5th, whatever. Patients not coming into the office, our volumes fell to nothing. So we need an increase in telehealth. And what did we do for that? We needed more staff training. Of course, we did the training. So just an idea on how you can enhance this report to make it a good one. We want you all to pass survey. The state's going to show up sooner or later. Right now, probably not so much. We're doing all surveys remotely right now. We still have to follow those up with an on-site, physical on-site after the public health emergency ends. But right now we're not traveling at all. So after you write all that, then you're going to review this report with your staff. Assignments are given as appropriate, and there's an attendance log. So we remember what's commonly missing on survey from our perspective is the report that puts it all together. You have all those pages, and then you never give a nice big summary, and you never give a training log. Not you never, but we see it missing sometimes. Sorry about that. That here's, okay, January 20th, here's what we discussed. We parsed it all out and we figured out what we can do better. We celebrated our successes, and here's the signatures of the people that were at that meeting, and you're golden. You've got your after action report, your event covered for the year. You could use March to March. It all depends on, you know, when your last one was. You'll have to base that on what you've got already done. Now, in the middle of a pandemic, we cannot forget surveys, our compliance. We must stay compliant with just what we do as rural health clinics. So do a self-survey, do a mock survey, walk through that clinic, take your checklist. If you don't have one, I'll send you one, and look at what we're doing well and what we're not. Okay. Some of the things that have changed are the cleaning process. Do we have it documented? Are we keeping up with it? Are we gotten slack because it's 11 months and we're so busy? We were busy with disease, we were busy with testing, now we're busy with testing and vaccines. So it keeps compounding and making your days harder and longer all the time. Your equipment, did you get Biomet check done? Has that guy been out? Is he coming out? If not, document it. It would be fine with us. I can tell you, I don't know about your state surveyors, but if he can't come out because of COVID, then document it, get something from him. We're not starting to travel again till May, whatever it is, if those pieces of equipment haven't been calibrated. Drugs that usually come as MDVs are showing up in SDVs. Please teach your clinic staff to, every time you pick up a vial, look at the label, look at the drug, look at the dose, look at the expiration date, and then is it an MDV or SDV? Look at the top. Has that seal been penetrated? If it's an SDV and it has needle marks, in the trash, okay? And if it's an MDV, of course, and it's dated with 28 days and we're good in date on the expiration date, you're good to go. Don't assume that everybody knows that. We are blown away by about 12 clinics in 2020 failed survey only because of this issue. So, and a lot of it happens because we're such creatures of habit, and we always got this drug as an MDV, and all of a sudden it shows up in our closets as an SDV. And it's even got a lot of many mLs in there. And so it's not a good thing, but you've got to train yourself every time, every time, every time. Of course, now we're doing testing for COVID-19. How's that going? Are you doing it in a tent outside? What's your process for that? Vaccine distribution with little notice. I just told you about the clinic yesterday that had that problem. Of course, we were happy to cancel that survey, bearing in mind, of course, we didn't buy a plane ticket, we didn't have a car rental, none of those things, and so it's a flexible time right now. It was unannounced, so we couldn't know what we were walking into on that phone call that morning. So it works out. Working in a mask, how hard is it to work in that mask? We're not operating room staff where we're used to masks all day long, where the temperature and humidity are very highly controlled. But in our offices, in our clinic spaces, it gets old. I don't enjoy going shopping anymore with a mask on. It just takes the fun out of it for some reason. But we have to work in them when we're around other people. And of course, you all do have to work in them all the time. Your lack of staff for the work to be done, where there's shortages everywhere, where people are sick, of course. And some of the smaller practices are particularly hit because they don't have that depth of people. Most rural doesn't have that depth of people, let's face it. Telehealth, less patients in the office. So how are you managing that? How are you billing that? Do we know how to bill that? Do we need help with that? All of those things. Now, HIPAA hasn't changed, although there's a webinar coming up that I do want to be on, that there are changes coming for HIPAA, but basically a pandemic doesn't make HIPAA go away. So we got to be conscious of that. How does that work with tracing? That's really a good question, actually. I might ask that on that webinar, but we have to know that we have to still secure our patient's PHI. Chart review seems to be something that kind of falls by the wayside because we're so busy, our providers are ill or they're somewhere else, and we need to make sure we're still doing our chart review. If you have to, go and change your policy, get everybody to sign off on it and drop the number. You can still do it, but at least you're doing it and meeting the standard by the law. Okay, so there's lots of little ways to get around some of these things that keep you on your feet, if you will, in the clinic. So that was really all I had. I apologize, that was only 25 minutes. But Rondi Ann mentioned something just when before we came on, and I'm going to offer something to you. We have put together certification for immunizations, for our pharmacies, for clinics, for anybody that's giving immunizations. And so I just wanted you to give you a little flavor of this for what that looks like. So if you look at the, so you know standards, right? Most of you know those. The beginning part is things that you typically do. Let me go back to the beginning so we don't get nauseous here on me. We just want to show you what this is, a typical set of standards. So we start with corporate compliance always. Oh, we're not starting there in this one. Administration, billing, human, yeah.
We can't see, we're not seeing your screen with
So
this information.
that would change what's, yeah, you're right. Thank you. Let me figure out how to do that. Share. Oh, Eric. Share whiteboard. Share a new whiteboard. No, share my screen. How about now? Yeah.
Universal standards.
Yes, perfect. Okay. So these are universal. This is our certification program. This is a certification, not an accreditation. So the cost is $1,500. It's not a major price. Anybody that would like these standards, I did just quickly call Sandy, who wrote these, our owner, and she's happy to do a call if Rondian would like with all of you to discuss this program. This is not my program, so I'm just going to give you a few highlights here and then we'll be good. But basically all our standards look at your practice. And if you're a rural health clinic, you've already got all this in place: admin, billing, human resources, quality improvement, and risk. If you're our clinic, I know that you have that for sure. We want to make sure that the people giving vaccines are well put together, let's put it that way. And rural health clinics are, because you're surveyed. And so we know that. So there's no problem with any of this. You've got a HIPAA program, right? You've got a process for receipt and disposition of orders. We know we have orders to administer these vaccines, right? From a provider. We have formal written contracts with subcontractors if they're delivering these vaccines, right? Billing and collection, we'll leave that one. HR, same, hiring, orienting, training. Have you trained these people? Do they know your process? What's your QI for this? How are you managing this vaccine distribution? Now, you can let me know you want these standards. I'm just going to scroll right on down to equipment management, not too much. Infection control, a whole lot in the vaccine distribution. Your patient services, I saw some things there in government regulatory that are a little different. And then your immunization, your testing services management, and long-term care, if applicable. There might be things in here that are NA for you, certainly long-term care. Long-term care would be. Your equipment meets every standard for RHC, so there's no new thing there. Same would be for your infection control. We're washing our hands. We're following standard precautions. We're using gloves. We're using PPE and to administer these vaccines. So I just want to get to your patient records. Absolutely the same. The dose that we and the lot number of what we deliver to the patient, absolutely the same, no different. And then they're going to get their little card. So that is that's critical. But let me get to the actual vaccine part of this, and then we'll take a couple questions. Okay, so the organization must have immunization services that meet the needs of your patients. Now, this could be used. We have pharmacies that sign up for this, and that's what I'm not on the pharmacy side, because I'm not so up on this. But they deliver immunizations in CVSs of the world, in your local pharmacies now, and so they get certified on this. It is a certificate, not an accreditation. So it's a very quick process, and they have a vaccine information sheet, right? I'm just looking for things that might be a little different. Informed consent, appropriate staff with training that delivers these, manufacturer's guidelines, State Board of Pharmacy guidelines, CDC. If you have questions about vaccine, and Rondi, and I got your question answered, there is a checklist on the CDC website. I just asked Sandy that. It's there. Please download that and then pass that around so that you have a checklist for administration of the vaccine. That's a good, she said the resource is amazing on the CDC website. Of course, you're going to have epinephrine in the clinic when you're administering, or if you're administering these in the parking lot or in another building that's not part of your RHC, you would certainly have that drug available. And people are sitting and waiting a recommended time until they can leave the building. And your storage, of course, that's a big deal, depending on if you get the Pfizer one or the Moderna one. So they got to be inspected on delivery. Vaccines are monitored while stored. Temperatures are monitored in the refrigerators. Vaccines that require diluent reconstitution, not these, or two components, are stored together in a reusable bag, resealable bag. The vaccine is labeled to remind staff to use both vials, depending on what you're administering. Other vaccines, not necessarily the COVID-19 vaccine. Expiration dates are monitored, of course. A written plan in place to address emergency situations, transporting of vaccines following CDC guidelines. Probably not too much of that. You're going to get it delivered, and then you're going to administer it probably as quickly as possible. And we're going to follow the CDC recommended vaccine schedules. Now that's going to refer to other kinds of vaccines that you're administering in your clinics. Although that is going to go with the 2-week business. So you're going to have a one now and then one 2 weeks later. You're going to report all adverse effects. That's very important, especially right now, because they're looking to make sure this is safe, and it appears to be across the nation. We have not had much problem, although we're hearing some resistance to take it in certain sectors, but we've seen maybe one major issue, and who knows what the other part of that issue was. We never know what the underlying aspects of that were. Then there's one for children. Note that there's no COVID yet for children. They are beginning some testing, but but if you're administering to COVID, vaccines to children, then you may want to get this certification. So it's just something to think about that's a little different. This is still all children, so I don't think there's any more for me to share. I don't believe. Okay, and testing. So this is a point of care COVID-19 testing services to meet the needs of your patients. You can get certified for this if you're doing this in your clinic. We're already doing it, I get that. But if you have need to prove to your patients that you know how to do this, we would be delighted to certify you for that. That's not me, that's a different group, but still. In a rural health clinic, you're going to make sure you have a waived test to be doing your COVID testing, not one that requires a different CLIA, because there are different tests, some more complex than others. And that's something that, if you didn't know that, that's an important process. Following the manufacturers, again, the manufacturers' guidelines, the State Board of Pharmacy and CDC guidelines for specimen collection, handling, transfer, and shipping. Most of us are doing the testing, but we're transferring that test to somewhere else to be actually done. And then long-term care we don't need. So that's about all I have. At this point, I would be delighted to send this out to anybody. There's a short application that goes with it, and I would take some questions.
Thanks, Kate. There are no questions in the chat box.
Okay.
At this time. I know that I did get a question earlier. They were recently surveyed, and there was a couple areas that they had deficiencies in. But looking at the waivers, can they bypass those deficiencies potentially and use the waivers as a way to remove the deficiencies?
So the state has a very robust appeal process. You would have to go to your state agency and find out what the appeal process is. Usually it's rather quick. So you get your statement of deficiencies, your 1561, and then you appeal in writing, and you still have to do a plan of correction. But I would put in my plan of correction, let's just say it's we didn't have an NP. She was pulled to the hospital, or she's ill and we couldn't cover the 50% of the time. Then in my plan of correction, that's how I would write it. This is covered by waiver number, and you would definitely need to go to that website and get the specifics on that. Put the website there and write it up that this is covered because we are in a public health emergency, and that has not been lifted. And see where you get with that. But that you got good grounds if that's the case. If you are already a rural health clinic with a billing number, yes, I would. But you'd have to find out what your appeal process is in Oregon.
Okay. We do have a question. In regards to documenting training attendance logs, we have been advised to have in-person meetings so information is passed along through email and morning huddles. How do you suggest we document this?
So they're electronic meetings. Is that what you're saying?
In regards to documenting training logs, we have been advised to have in-person meetings. So information is passed along through information and morning huddles.
So if they're in person, we can sign a sheet of paper. I'm not quite getting it, but I'm thinking if everybody's on a like this.
We do not have in person.
Okay. Okay. All right. So that is a great question. So that is a great question. Thank you for that one. I have not heard that. I would probably, you know how everybody's on the screen when we get a meeting, you got 7 or 8 people, we're all talking on a Zoom call. I'd take a screenshot. That's what I would do. And I can prove you were there by that picture. It's date stamped, and I'd print it out, put it in my book or something, or in my file somewhere, electronic file, or that's what I would do. I don't know how else you can prove that they're there. But take a screenshot of the screen. That works. That's a great question.
Yeah, that is a great question.
Virtual training proof. Oh my goodness. I'm going to take that one to our training on the 1st of February. Thank you, whoever sent that.
Christy Frazier.
Thank you, Christy. I love it.
Are there any other questions at all? Okay, well, Kate, I think I'm going to be giving back some time to everyone. Thank you for your presentation today. You always provide Oregon RHCs with useful information to move forward in their day-to-day operations, and we appreciate that.
Thank you.
Also, RHCs, Kate will be back with us on February 23rd to present a webinar on survey preparation. And I will be sending registration information out on this event within the next week.
So may I say something there?
Yeah, go ahead.
So I never get this opportunity to talk to the group. So prior, this far ahead of a presentation, I would love to hear confidentially, no names will ever be attached. If you could email me at khill@thecomplianceteam.org, you see that there on the screen, I think. What is your most troubling aspect to stay compliant? Boy, would I love to have that. So I can help you more. That would just be terrific. You can send them to me, you can send them to Rondianne, and that'll help me to prepare to hit what's the hardest for you. What's the hardest aspect of compliance? Seriously, please, that would just be awesome. You'd help, and I promise you, you're going to help a lot of people around the country with that information as well. No names, for sure. Okay?
Okay. That'd be wonderful.
Yeah, I think so too. Thanks. Thanks for that.
Okay, thank you, everyone. I'll be giving you back 20 minutes, and we will see you again soon. Thank you, Kate.
Thank you. Be safe out there.